Hey Doc, how's it going?
Hi, how can I help you?
Hi. So, over the last few years, I've been coaching multiple youth baseball teams, and I've noticed that many of my pitchers have been diagnosed with the ulnar collateral ligament injury. Do you have any suggestions on how to prevent them?
Yes, believe it or not, it is a common issue amongst youth baseball pitchers. First, it is important to understand the anatomy behind the injury. After discussing this, you will be able to
Learning objective number 1. Explain the biomechanical functions of UCL injuries. Define the 3 grades of UCL injuries.
Before we get started, let's test your current knowledge.
The valgus stress test is an assessment for UCL injury. When performing the valgus stress test, be sure to locate the medial epicondyle and ensure the testing arm is slightly flexed. Next, stabilize the forearm and apply a force on the lateral side of the elbow. Be on the lookout for excessive laxity and any signs of pain or discomfort.
The elbow is a hinged joint, which has a unique ability to rotate the distal arm. Within the elbow is the ulnar collateral ligament complex. The ulnar collateral ligament, or the medial collateral ligament, consists of 3 bundles: the anterior and posterior oblique ligaments, as well as the transverse ligament. The anterior oblique ligament primarily contributes to the stability of the elbow. The anterior oblique ligament originates from the anterior and inferior portion of the medial epicondyle and inserts the tubercle of the ulna. The anterior oblique ligament has 3 functional bands, which include the anterior, central, and posterior bands, which resist valgus stress throughout the range of motion. Repetitive external rotation of the humerus leads to excessive valgus strain at the elbow joint, which can cause the anterior bundle to be torn. Injury to the ligament can result in 3 grades. A grade 1 injury consists of the straining of the UCL, but no tear has occurred. Grade 2 varies in their degree of injury, however, generally occurs when there is a partial tear to the ligament. Lastly, a grade 3 tear, the most damaging, is when a complete or full thickness tear of the ligament has occurred.
Now that I know how the anatomy behind it works, is there a pitch that I should avoid?
Please take a minute to go onto our class Twitter to vote on which of the pitches poses the greatest risk for UCL injury.
According to Petty et al., fastballs thrown over 80 miles per hour are not advised because it puts too much torque on the UCL.
How do I spot the injury before it occurs? And are there any strategies to prevent it?
Oh, that is easy. First, we need to identify the risk factors.
Learning objective number 2. List 3 risk factors in youth pitchers that may lead to UCL injuries, and describe 3 prevention strategies that could lower the risk for UCL injuries.
The greatest risk factor for developing a UCL injury in youth pitchers is fatigue. When a pitcher continues to throw while his or her arm is fatigued, the rate of developing a grade 3 tear and requiring surgery increases 36 times. Related to fatigue, the number of pitches thrown is a considerable factor for developing a UCL injury. For pitchers under the age of 14, throwing breaking balls, such as a curveball, can put significant strain on their joint, which the UCL is unable to handle while the player is in their growth phase. When these pitchers throw fastballs above a speed of 80 miles per hour, the valgus torque created reaches the upper limit that their UCL is capable of maintaining. When not on the mound, having the pitchers play the position of catcher as well increases the amount of throws made, leading back to the previously mentioned risk factor. Not allowing the athlete an adequate amount of time to warm up prior to pitching is a risk factor for developing a UCL injury as well. Lastly, if the athlete continues to pitch throughout the presentation of pain, there is an increased likelihood of progressing into a UCL injury.
In conjunction with the amount of pitches thrown, the type of pitch is important to monitor. Limit youth athletes to throwing fastballs below a speed of 80 miles per hour, especially in large volumes. As well, while the athlete is under the age of 14, it is important to restrict the use of curveballs, as their growth plates are not fully developed and their UCL is at greater risk of tearing due to the increased valgus torque caused by the biomechanics of the curveball. The biomechanical signs of fatigue to watch for and respond to include decreased ball velocity, decreased accuracy, upright trunk during pitching, dropped elbow during pitching, and/or increased time between pitches. Also, be aware of the physical signs, which include the pitcher looking fatigued and complaints of fatigue or pain. The recommended guideline for youth pitchers is to take at least 2 to 3 months, 4 months is preferred, off from overhead throwing of any kind. This allows for adequate rest and recovery. Year-round baseball is not recommended due to overuse of elbow and shoulder. As for in-season recommendations, a pitcher should not pitch any back-to-back games. Lastly, have the athlete perform a warm-up to get the synovial fluid in the joints moving and the ligaments loosened. This plays an important role in the prevention of a UCL injury.
That was helpful, but I have a pitcher who's currently suffering from elbow pain, and he's considering surgery. What are your thoughts on surgery versus conservative treatment?
Learning objective number 3. Discuss when surgical treatment or conservative treatment is appropriate.
Well, there are a few factors you should take into consideration. Using the shared decision-making model, which consists of the athlete, the skills required for treatment, and evidence supporting the treatment plan, we can figure out the best course of action.
In that case, let me call the athlete in.
Sounds good.
Hey, coach.
Hi, Maddie. Have a seat.
Thanks.
So, Maddie, I hear you're contemplating surgery. Do you have any reasons for considering surgery?
Yes, my doctor told me for grade 3 UCL injuries, reconstructive surgery is the recommended form of treatment. In a paper by Redler et al., 2016, one study reported a return to play rate of 63% in professional baseball players with a complication rate of 32% in dealing with ulnar neuropathy.
Well then, have you considered that with grade 2 UCL injuries or lower, conservative treatment has been shown to yield good results as well? A study by Ford et al. 2016 showed professional pitchers with grade 2 or lower UCL injuries returned to play at a rate of 93%. Furthermore, 94% returned to the same level of play prior to their injuries.
What about the study by Kane et al., which reported on the outcomes of 743 patients who underwent the modified Jobe reconstruction method? Patients had an 83% return to play rate with only a complication rate of 20%.
Wow, you're so knowledgeable, Maddie. In any case, if you do end up choosing the conservative route, there are 2 phases you should be aware of. Phase 1 involves re-establishing range of motion to pre-injury levels and controlling for pain and inflammation. Phase 2 involves muscular strengthening and conditioning. The Throwers 10 program, which aims to strengthen and stabilize the shoulder and the elbow, is one of many options.
Oh, I heard that program. If you want to know more about the Throws 10 program, check out the link in the description box below.
Cool. Can't wait to tell my team what I've learned today.
Wait, do you know the extent of your injury?
Good question, Maddie.
I don't know, but now I have all the necessary information I need to make an informed decision.
Thanks.
Now that you've been informed on youth UCL injuries, let's see how much you know. What is the mechanism of UCL injury? Next, in which cases would a conservative treatment or surgical treatment be better for an athlete with a UCL tear? Lastly, what are 3 possible risk factors and 3 preventative strategies for UCL injury?